I'm Dr. Chinyere Ugorji, a 2007 graduate of American International School of Medicine with 10 years of clinical experience working as a certified nurse aide at various hospitals, long-term acute care facilities, nursing homes with patients in their private homes. From doing my clinical rotations here in the United States, from 2 graduate medical education programs, Henry Ford Internal Medicine Residency Program, Detroit, Michigan, Springfield Family Medicine Residency Program, Springfield, Illinois, from various observer shifts and expert shifts, and from my various preventive health care fairs where I've had the opportunity to have hands-on experience with research experience from UT Southwestern in the psychiatry department, working with Dr. Caroda and Stella Downs, who are both awesome people, with a master's in business administration with an emphasis on public administration at Davenport University, Grand Rapids, Michigan. I'm currently involved in preventive care practice at various community churches and also at various charity works and home visits. And I want to welcome you to Dr. Drchikitomentoring Ustream show, broadcasting live today. I want to thank everybody who has been following the series. We've talked about lots of interesting topics over the past week. And I want to thank everybody who has been answering the Powerball question, who has been contacting me. Today we're talking about a very interesting topic, and I'll start by presenting the case study, which is designed to help us to learn together. So the case study, a 55-year-old male complains of blood in his stool. He has a history of constipation that started 6 months ago, consisting of 2 bowel movements a week. 1 month ago, he noticed blood reached his stool at every bowel movement. During the last 2 days, he started to have tenesmus and watery brown diarrhea 3 times a day mixed with blood. He has no urgency, no mucus or stool, and no pain during defecation. He denies any fever, chills, nausea, vomiting, abdominal pain, recent history of travel or contact with ill persons. He recalls a 10-pound weight loss during the last 6 months despite a good appetite. His diet consisted of a lot of junk food with no vegetables. Review of system, negative receptors above, allergies, no known drug allergies, medication, used to take many laxatives, bisacodil and phenolphthalein, but stopped after the onset of diarrhea 2 days ago. Past medical history, bronchitis 3 weeks ago, treated with amoxicillin. Past surgical history, hemorrhoids resected 4 years ago. Social history, no smoking, no alcohol, no illicit drugs. Sexually active with wife only. Family history, father died of colon cancer at age 55. So at this point, I'm sure you have some differentials that you're thinking about. You know, many things you think could actually be wrong with this 55-year-old male, and yeah, and I'm sure you have some things that you're thinking could be wrong. If you're thinking it could be angiodysplasia, or it could be ulcerative colitis, it could be Crohn's disease, it could be an intestinal obstruction, it could be pseudomembranous colitis, it could be other infectious colitis, it could be an ileus, it could be carcinoid. You know, you may not be too far from the answer, but hopefully by the end of the show, we might be able to learn together why this man has colon adenocarcinoma, which is actually the topic of today. So I'm going to be talking about colon adenocarcinoma, and first of all, we want to know what it is. Well, it's actually defined as a cancer from uncontrolled cell growth into the colon or rectum, any part of the large intestine, or even the appendix, and that's from Wikipedia 2013. So what actually causes it? Well, you know, most times it's actually caused by genetic factors, and that's like 15%. So that's not percentage. A large amount of it is caused by other factors, and that includes people who have no genetic risk. And some other things that actually causes it includes environmental exposure. That's diet, some inflammatory conditions of the digestive tract. Risk factors too can also cause it too, and those risk factors include older age, male gender, high intake of fats, alcohol, and that's if you take more than 1 drink per day, or red meat, obesity, smoking, and lack of physical exercise. That's insufficient activity can actually cause it. So how common is this? Well, from the American Cancer Society, and also from an article from Up to Date, 148,810 individuals will be diagnosed with colorectal cancer what symptoms are actually common in this disease? Well, iron deficiency anemia, rectal bleeding, abdominal pain, change in bowel habits, intestinal obstruction or perforation. On physical exam, what physical exams do you see? Well, early in the onset of the disease, you see some non-specific findings like fatigue and weight loss, or even no symptoms at all. And then also more later on in the disease, you actually see abdominal tenderness, macroscopic rectal bleeding, palpable abdominal mass, hepatomegaly, and ascites. The differential diagnosis. What else should you be thinking as you see somebody who has all these symptoms during rounds or in your clinics? And what other if you present with these symptoms of the patient, what other things should you think could actually be wrong? Well, it could actually be an arteriovenous malformation. It could be carcinoid, like I talked about earlier. It could be Crohn's disease. It could be diverticulosis. It could be gastrointestinal lymphoma. It could be an ileus. It could be ischemic bowel. It could be small intestinal carcinoma. It could be ulcerative colitis. It could be hemorrhoids. It could be pseudomembranous colitis. It could be other infectious colitis. And how do we diagnose it? Well, a combination of lab tests and also a combination of imaging and procedures will also help us to diagnose it. So the lab tests include complete blood count with differential routine, basic metabolic panel routine, thyroid stimulating hormone routine, liver function test, fecal occult blood test, carcinoembryogenic test, a stool for C. difficile toxin and fecal leukocytes. In terms of imaging, double contrast air contrast barium enema is used. A computed tomography of the abdomen or pelvis is used. And with contrast too, it's actually quite helpful to use contrast sometimes. And then also a colonoscopy too with a biopsy. And how do we treat it? Well, the medications are actually pretty intensive. Most of the time, for the symptoms of anemia, you have to replace the iron, so you give oral iron sulfate. And then for the anti-cancer drugs, there are lots of combinations that are actually used and which are quite efficacious according to recent published trials. So and I'll list most of them out. So you have 5-fluorouracil plus glucovorine, and that's low-dose glucovorine. The 5-fluorouracil is 500 milligram IV weekly for 6 weeks, and the glucovorine is 20 milligram IV weekly for 6 weeks, and it's actually administered before the 5-fluorouracil, and you have to repeat the cycle every 8 weeks for a total of 24 weeks. Now, 5-fluorouracil is also called Adrosil, so that's another name for 5-fluorouracil. And glucovorine is also called folinic acid. Now, the other drug is the Grammont regimen, and that's 5-fluorouracil given as 400 milligram IV bolus, followed by 600 milligram IV continuous infusion for 22 days on days 1 and 2. And then glucovorine or folinic acid, 200 milligram IV on days 1 and 2 as a 2-hour infusion before 5-fluorouracil. And you have to repeat the cycle for every 2 weeks for a total of 12 cycles. Oxaliplatin plus 5-fluorouracil plus glucovorine is actually a combo known as 4-FOX4. So you have oxaliplatin given as 85 milligram per liter square IV on day 1, and then 5-fluorouracil given as 400 milligram IV bolus, followed by 600 milligram IV continuous infusion for 22 hours on days 1 and 2. And then glucovorine given as 200 milligram IV on days 1 and 2 as a 2-hour infusion before 5-fluorouracil. And you have to repeat this cycle every 2 weeks for a total of 12 weeks. Now, for metastatic disease, that's disease that has spread to other places, you can actually give irinotecan, which is also known as Camtosa, and that's plus 5-fluorouracil plus glucovorine, and that's actually a regimen known as the 4-4 regimen. So irinotecan is 180 milligram per liter squared IV on day 1, and then 5-fluorouracil is given as 400 milligram per liter squared IV bolus on day 1, followed by 2,400 milligram per liter squared IV continuous infusion for 46 hours. And then leucovorin is 400 milligram per meter squared IV on day 1 as a 2-hour infusion prior to 5-fluorouracil. So normally you give leucovorin before you give 5-fluorouracil, and you repeat the cycle every 2 weeks. Now, oxaliplatin plus 5-fluorouracil plus leucovorin is actually known as 4-4-6. And oxaliplatin you give 100 milligram per meter squared IV on day 1. You give 5-fluorouracil 400 milligram per meter squared IV bolus on day 1, followed by 2,400 milligram per meter squared IV continuous infusion for 46 weeks. And leucovorin is 400 milligram per meter squared IV on day 1 as a 2-hour infusion before 5-fluorouracil. Repeat cycle every 2 weeks. The 4-4-7 is oxaliplatin plus 5-fluorouracil plus leucovorin, and that's oxaliplatin given as 100 milligram per meter squared IV on day 1, 5-fluorouracil 3,000 milligram per meter squared IV continuous infusion on day 1 for 46 weeks, and then leucovorin 400 milligram per meter squared on day 1 as a 2-hour infusion before 5-fluorouracil, and you have to repeat the cycle every 2 weeks. Now, capecitabine plus oxaliplatin is known as Zelox. And capecitabine is also known as Zeloda. That's the trade name. So and that's capecitabine or Zeloda given as 850 to 1,000 milligram per meter squared BOBID on day 1 to 14, and then oxaliplatin given as 100 to 130 milligram per meter squared IV on day 1, and you have to repeat this cycle every 21 days. Now, 4-FOX4 plus bevacizumab, you have oxaliplatin given as a 5 milligram per meter squared IV on day 1, and then 5-fluorouracil 400 milligram per meter squared IV bolus, followed by 600 milligram per meter squared IV continuous infusion on day 1 and 2, and then leucovorin 200 milligram per meter squared IV on days 1 and 2 as a 2-hour infusion before 5-fluorouracil, and then bevacizumab is 10 milligram per kg IV every 2 weeks, and repeat cycle every 2 weeks. Bevacizumab is also known as it's actually another drug that is also used for colon adenocarcinoma. So that's the combo. It's actually quite precise, and you have to follow the instructions and also follow the regimen to be able to get efficacious results. And then for the procedures, colonoscopy, anoscopy, flexible proctostigmodoscopy has actually been very useful in terms of producing results. And then consults, you have to have a gastroenterologist on board, and that's because you might actually have to have a colonoscopy. And also, in case you have to have a surgery, then a colorectal surgeon has to be on board too. In terms of counseling, well, the patient has to be counseled in terms of contraception, medication compliance, safe sex counseling, smoking cessation, no alcohol, no illegal drugs, driving with seatbelt, and regular exercise. Preventive care, for his age, he needs aspirin to prevent any coronary vascular disease, and that's for men. It's 45 to 79 to prevent a myocardial infarction. And also, he also needs colorectal screening. That's for adults at age 50 and continuing until age 75. He also needs HIV screening. That's for any adolescents or adults. He also needs high blood pressure screening. He also needs lipid disorders. He also needs alcohol misuse screening, depression screening, healthy diets, counseling, hepatitis C, virus infection if you fall into the range. And then he also needs obesity counseling, and also type 2 diabetes mellitus. Now, something important about the classification is something called the TNM classification. And this is actually from a very good article from eMedicine by Dragovich, and it classifies it based on the extent of involvement of the colon, that's the T, and then the N is the extent of involvement of the lymph nodes, and then also N is in terms of metastasis. So TX means no description of tumor extent possible because of incomplete information. TIS means in situ carcinoma involving only the muscularis mucosa, and TID TI means cancer has grown through muscularis mucosa and extends into submucosa. And T2 means that cancer has grown through the submucosa and extends into the muscularis propria. Now, T3 means that cancer has grown through the muscularis propria into the outermost layers of the colon, but not through them. It hasn't reached any other nearby organs. T4A means that cancer has grown through the serosa or the visceral peritoneum. And T4B means that cancer has grown through the wall of the colon and is attached to or invades nearby tissue or organs. And NX means no description of lymph node involvement possible because of incomplete information. N0 means no cancer in nearby lymph nodes. N1A means cancer cells found in one nearby lymph node. N1B means cancer cells found in 2 to 3 nearby lymph nodes. N1C means small deposits of cancer cells found in areas of fat near lymph nodes, but not in lymph nodes themselves. N2A means cancer cells found in 4 to 6 nearby lymph nodes. N2B means cancer cells found in 7 or more nearby lymph nodes. M0 means no distant spread seen. M1A means that cancer has spread to one distant organ or set of distant lymph nodes. M1B means that cancer has spread to more than one distant organ or set of distant lymph nodes, or has spread to distant parts of the peritoneum. So let's say that we have a case where on biopsy we find out that I'm pulling up the biopsy results here. That the cancer has grown through the submucosa and in the muscularis propria, and is found in one nearby lymph node and also found in the liver. So that gives it a T2 because it has grown through the submucosa and in the muscularis propria. It's found in one nearby lymph node, so that's an N1A, and also because it's found in the liver, which is a distant organ, that's an M1A. So that's T2, N1A, and M1A, and that's the classification. So it's pretty, pretty specialized, but that's actually used in terms of treatment and also in terms of classification, and it's very important to understand how that works. Now, in terms of monitoring post-resection after surgery, what else do we need to do? What else do we need to follow up with the patient in terms of monitoring? Well, you have to do a clinical examination with CEA 125, and you have to repeat it every 3 months for 2 years, and then also later on you repeat it every 6 months for up to 5 years. You have to focus on areas like ostomy problems or stool incontinence. You also have to focus on rejection, proctitis. You also have to focus on bowel adhesions, and also do a colonoscopy. You have to do it at 1 year and also at 3 years post-resection, and then repeat it every 5 years. And then ultrasound or CT abdomen to evaluate the liver, you have to consider every 4 to 6 months for 3 years, and that's actually per local guidelines. In terms of prevention, you also have to recommend high physical activity, high fruit and vegetable intake, high dietary fiber intake, high folate or methionine, high dietary calcium intake, and that's normally 1,200 milligrams every day. So this patient actually has colon adenocarcinoma, and that's the final diagnosis. And in your clinics, how do you code for colon adenocarcinoma? Well, the coding is actually ICD-9 153.0, 159.1, and ICD-10 C18, C20, C21. ICD-10 is actually not being used currently, but it's going to be used in the near future next year. So I have a PowerPoint question that is actually designed to be able to promote an understanding of the content, and the question is colorectal cancer, commonly known as colon cancer, bowel cancer, is a cancer from uncontrolled cell growth in the colon or rectum, parts of the large intestine or the appendage, true or false. So I'll let you figure that out. Check that out. Read the article. It's a pretty good article that has a good content of colon cancer, and I would also want to urge you to submit your PowerPoint question so that we can be able to have the drawing on Saturday when I do my broadcast for Live the Night Walk, and there are lots of prizes that can be won. We have a lot of sponsors from various medical education programs, various residency programs, from various organizations, and once you submit the Powerball questions, you can be able to win prizes and be able to um, learn together. On Monday we talked about cholecystitis, and on Tuesday we talked about humeral fracture. On Wednesday we had to cancel the Oscar session because of connectivity and logistic problems. And then on Thursday we also talked about infectious mononucleosis. On Friday we talked about, today we talked about colon adenocarcinoma. So keep on submitting your Powerball question answers. The questions can be found on my webpage www.drchikitomentoring.com. And but I'm just gonna talk about it briefly. For cholecystitis, the Powerball question is an estimated 10 to 20% of Americans have gallstones, and as many as one third of these people develop acute cholecystitis. True or false? So answer that question, and you can be able to be eligible to win prizes. And then for humerus fracture, the question is humerus fracture are caused by direct trauma to the arm or shoulder or by axial loading transmitted through the elbow. True or false? So if you answer that question, you can be able to win a prize. For infectious mononucleosis, the Powerball question is EBV is transmitted via intimate contact with body secretions, primarily oropharyngeal secretions. True or false? So if you answer that question, you have a chance of winning a prize. And we also talked about the Powerball question for today. And then on physical examination for colon adenocarcinoma, we're gonna have the Oscar session next week Thursday, and we'll talk about it and with demonstrations. We don't have a live SP, but we'll use a substitute model, and we can be able to demonstrate it. But I would do a basic cardiovascular examination auscultation, a basic pulmonary examination auscultation, and for the abdominal examination, I will auscultate, palpate, and also percuss for any organomegaly. So today, for the residency interview session of today, we're going to answer how do you handle confrontations? Who are your heroes? So those are the two questions that we are going to answer today. And the answers to those questions can also be found on my website. So if you ask how do you handle confrontations, I would say communication is the key to handling confrontations, and I've handled confrontations successfully in the past, utilizing a good understanding of the team member's personality, role in the team, and perspective. So that will be able to give the interviewer an insight into that person. And you can actually use a real life example. You can tell them that I have actually encountered a confrontative atmosphere at work where a team member asked me about my job performance, and asked me why I did something, and that I actually took the time to get him to talk to me about it, and I actually explained to him my reasons for doing that, and at the end of the whole episode, I was actually able to convince him about my reasons for doing what I did, and that way the confrontation was actually avoided. And then another question that you could be asked is, who are your heroes? Well, I would say my heroes include people who have contributed towards healthcare reform in recent past, and there are lots of healthcare reform leaders, and those are my heroes. So that would be my answer to that question. And that's two examples of questions that could be asked at the residency interviews. Healthcare news is going to be featured from Monday. It's going to be updated on my webpage and also featured for a few minutes. And there are lots of exciting things going on in healthcare. And you can be able to be part of it by listening to Dr. Drchikitomentoring Ustream show. And then also for my work, I want to thank everybody who has been supportive, who has donated, who has who has actually been part of the work. And I want to thank my team members. And I have a 9 people team, and they all have their web pages. They also have their Facebook pages, and they actually create awareness. They raise funds about the for the work, and they talk about the work, using the web pages and using their Facebook pages. And I just want to thank them for being so supportive, and for sharing the mission behind the Light the Night work, which is a work for leukemia and lymphoma, is blood cancer. We've been having daily emails and communication. We've been having online meetings. We've been having individual fundraising activities, and I just want to appreciate them again. Um, and then in terms of the funds raised, we've actually raised $29. Our top donors are Brian Downey. He's our top donor right now. Our most recent donors are KinderCare. So I want to thank KinderCare once again. The employees have been so awesome. That's a very wonderful place to be able to take to send your kids to. They provide child care, and they can be found everywhere in every city. So I want to thank them. They've been so awesome. And then available opportunities. There's a TV contest going on. So the top 20 to register. No, the top 20 champion for fields, which means raising $100, will actually be registered for a chance to win a TV contest. So it's actually currently on right now, and we actually don't fall into that. Dr. Drchikitomentoring is still racing towards becoming the champion for fields, which means raising $100. Right now we've raised $29, and we're still welcoming donations. If you can be able to donate towards our team, we can be able to be in the drawing for this TV. And then also some of the things that I do at Dr. Chiki, and then also in terms of the Light the Night website, they have a lot of information about this contest, and then also in terms of social media, they have pictures from Light the Night work in Atlanta, and then they also have something about WX Smith Wines, who are actually helping to raise funds, and all the purchases, 20% of the purchases actually go towards Light the Night work. So that is actually pretty impressive, and that's also featured on Twitter. And on Pinterest, they have a lot of boards with things in training. They also have lots of videos on YouTube on play to kills, and then on the blog they have pictures from the conference, and also updates from the conference on patient health advocacy summit that took place on the 15th of October. No, that was posted on the 15th of October. So I want to urge you to check that out. There are lots of things that are going on, and we can all be part of that to be able to create awareness about leukemia and lymphoma. And then some of the services that we offer at the Drchikitomentoring preventive care include free health assessments at community churches, charity works, and also home visits too. With being part of a team, we can be able to offer you free health assessments if you invite us to your church, to your charity work, or to your home. We can be able to do that. You're qualified. I'm also willing to train. I'm also actively recruiting for people who are interested in being able to join my team. I also do tutoring too. All that information can be found on my website. I'm also part of the Town Wars, which is actually a smoking cessation campaign, which has actually been very successful in the past. That's part of the American Academy of Family Physicians efforts to be able to create awareness about smoking. And then I also collect some box tops and labels for education. Town Wars, what's going on at Town Wars? Well, they have the national contest, they have the poster contest, and also the video contest, and that's actually at the national and also at the state level. So at the national, for the poster contest, the national contest prizes, first place is 1,500, second place is 250, and then third place is 275. And then at the state level, if you win, you have a chance to attend the Taiwan's National Conference. For the video contest, for the state level, if you win, you also have a chance to attend the national Taiwan's National Conference. And then at the national level, first place is actually 750, second place is 200, and then third place is 100. So those are lots of opportunities for schools, to be able to get their students to be involved in tire walks, to be able to be involved in smoking cessation. And I want to urge all of you, I have a Facebook fan page. I've been contacting schools to be able to get them to be involved, and hopefully we can be able to get some little kids to actually win, some of these new prizes. There are lots of upcoming deadlines that you can be able to beat and be able to be part of Star Wars. This is a campaign for smoking cessation. I want to thank the Restored Christian Ministries. I want to thank Pastor Austin and Pastor Virginia Akolam, who have actually asked us to give us permission to be able to use their church, and we have free preventive health screenings there. Every Sundays after service, you can be able to come by there, have a good service, and also be able to have your preventive health assessments done free of charge. There's also free breakfast too. It's a wonderful church. I've actually my life has actually changed being a member of that church, and I want to thank them for that opportunity. And I also want to ask healthcare professionals to be, and also family members too, to be able to submit their case studies too. You can be able to win prizes if you submit your case studies. And with that, I want to thank everybody who has logged into Drchikitomentoring Ustream show for today. There are lots of exciting things going on in healthcare, and we are actually proud to be in the forefront of all of that, providing you with case studies, solutions to case studies, and preventive healthcare topics on Drchikitomentoring Ustream show. Feel free to post on my wall, feel free to comment on the video, or feel free